Hi everyone! Today I will be presenting on my research titled Predictors of Toxicity from PARP Inhibitors, a Focus on BRCA Status. Here are the disclosures of my co-authors for your reference. DNA sometimes suffer damage, however cells have several mechanisms for making repairs. When both DNA strands are damaged, cells use tumor suppressor genes such as BRCA to help repair breaks. Unfortunately, there are cases when there are mutations in BRCA genes preventing proteins from making repairs. These mutations are most commonly seen in the breast and ovarian cancers and can either be inherited, which are germline mutations, or acquired over time, which are somatic mutations. The incidence rates of BRCA mutations are 5 to 10% and 10 to 15% in breast and ovarian cancers, respectively. BRCA mutations are associated with a high lifetime risk of developing either of these malignancies, especially when compared to those who are BRCA wild type without a mutation. Pancreatic and prostate cancers have been more recently associated with BRCA mutations, with about a 5% incidence rate. PARP are among the pathways similar to BRCA involved in coordinating and restoring damaged DNA. Specifically, the enzymes are responsible for detecting and repairing single-strand breaks. This pathway is particularly important in cells with BRCA mutations. PARP inhibitors rely on the concept of synthetic lethality, which I'll demonstrate in the subsequent series of images. When functioning properly, coordinated mechanisms involving BRCA genes and PARP proteins maintain the integrity of DNA and promote cell survival. In BRCA mutant cells, damaged DNA is not repaired properly via homologous recombination, and cells rely on PARP to repair DNA damage. In the presence of a PARP inhibitor, PARP becomes trapped on damaged DNA, resulting in a PARP DNA complex. Instead, cells rely on BRCA to repair DNA damage. The efficacy of PARP inhibitors relies on the concept of synthetic lethality, in which a cell can survive either PARP inhibition or BRCA mutation, but not both. PARP inhibitors have demonstrated efficacy and gained approval in solid tumor malignancies commonly associated with BRCA mutations. Most recently, olaparib gained an additional FDA indication in the pancreatic cancer population. Although PARP inhibitors are a more targeted mechanism of action than traditional chemotherapy, hematologic toxicities, including anemia, neutropenia, and thrombocytopenia, are common and can often be dose limiting. Although this is considered a class effect, there is variability in frequency of heme toxicities between the four agents. This disparity is attributed to the differences in each PARP inhibitor's ability to trap PARP enzymes in damaged DNA. An increase in PARP trapping has been associated with high rates of myelosuppression. So clinically, where is there a gap warranting further investigation? BRCA mutations impart an efficacy benefit with PARP inhibitors, but we don't know if it's a predictor of heme toxicities. Currently, parameters for dose reductions in the setting of hematologic toxicities are widely incomplete. Identifying risk factors contributing to heme toxicities associated with PARP inhibitors could be helpful in optimizing therapy. Therefore, the purpose of my research project is to assess the safety of PARP inhibitors and to determine whether BRCA status is predictive of hematologic toxicity. The primary outcome was incidence of CT-CAE grade 2 or greater heme toxicity in all tumor types. Secondary outcomes included time to first heme toxicity, the duration of these toxicities, treatment interruptions, reductions, and discontinuations, and finally, a characterization of off-label use. This table outlines the CT-CAE grading scale for heme toxicities for your reference. This study was a retrospective chart review of patients treated at Emory's Winship Cancer Institute receiving one of the four approved PARP inhibitors between December 1, 2014, which is when olaparib, the first PARP inhibitor, was approved, to November 1, 2019. Adults with any solid tumor malignancy who received at least one dose of a PARP inhibitor were included. PARP inhibitors in a clinical trial, pregnancy, and treatment at outside facilities were considered reasons for exclusion. A chi-square test was used to evaluate the primary endpoint, while mean standard deviations and ANOVA were used for secondary endpoints. Overall, 119 patients were chart reviewed and 88 met the outlined inclusion criteria. 31 patients were excluded as they either lacked follow-up or never started treatment. Patients were stratified based on BRCA mutation status into three cohorts: BRCA wild type, somatic, and germline mutations. The study population was majority female with ovarian cancer. Approximately, there were 1/4 of patients with a primary tumor type outside FDA-approved indications for PARP inhibitors, making off-label use very common. Prostate cancer accounted for the majority of the other tumors. Majority of patients were heavily pretreated with at least 3 lines of prior therapy. Olaparib was the most common PARP inhibitor prescribed, and finally, approximately 3/4 of patients were initiated on full-dose PARP inhibitor. Overall, there was no significant difference in grade 2 or greater heme toxicity based on BRCA mutation status. Additionally, anemia was the most common heme toxicity observed. In regards to secondary endpoints, there was no statistically significant difference noted among groups, with the exception of off-label use favoring BRCA wild type, which we would expect to see. I'd also like to point out the increased incidence of off-label use in the somatic mutation cohort. Here's a visual representation of the time to first heme toxicity stratified by BRCA mutation status. The BRCA wild type group had the highest cumulative incidence among cohorts. You can see within the first month of PARP inhibitor initiation that the BRCA wild type group had a 50% cumulative incidence, while the 2 BRCA mutation groups had a cumulative incidence of only 30% at that same point in time. As a single-centered study, there is a potential of PARP inhibitor selection bias and inconsistent starting doses between providers, making it difficult to truly assess a strategy. Additionally, documentation of BRCA status was occasionally omitted, which excluded some patients. As mentioned previously, the majority of patients were heavily pretreated with cytotoxic chemo. Cumulative toxicity could lead to decreased tolerability of PARP inhibitors. And finally, the small sample size did not allow for each PARP inhibitor to be assessed individually. In conclusion, the incidence of grade 2 or higher heme toxicity was similar despite the differences in BRCA mutation status. There were no significant differences in the incidence of secondary safety outcomes, although off-label use was significantly more common in the wild-type cohort. Olaparib was most commonly used PARP inhibitor, with the majority starting on full dose. And finally, as PARP inhibitors continue to become more widely used, larger studies are needed to further characterize parameters for starting dose reductions for each PARP inhibitor separately. What is the most common and often dose-limiting toxicity seen with PARP inhibitors? The answer is hematologic toxicities. I'd like to acknowledge the co-investigators and statisticians, and that concludes my presentation. I'd be happy to answer any questions via email. Thank you.